Whether you're a parent, an aunt, a doctor, or just, someone who used to be a kid, treating a child isn't just about adjusting a dosage for their size. It's actually about navigating an incredibly delicate tightrope. We have to balance a child's growing independence, a parent's natural drive to protect their offspring, and a doctor's fundamental absolute duty to do no harm. So, in this explainer, we're going to break down exactly how the law and medical ethics work together to solve some of the absolute most emotionally charged dilemmas in all of healthcare. Okay, let's kick things off with our guiding North Star from the General Medical Council. This really sets the ethical baseline for everything we're going to discuss today. It sounds so incredibly simple, right? Act in the best interest of children. But as you'll see, when the stakes are literally life and death, defining what that best interest actually looks like can be one of the most agonizing challenges a medical professional will ever face.
To make sense of it all, we'll be covering 5 core areas in this explainer. The legal foundation, who gets to decide, determining best interests, when people disagree, and finally, the rules of confidentiality.
Let's start right off with part 1, the legal foundation.
Now, understanding these laws is absolutely crucial because they really form the very ground doctors walk on every single time a child enters their clinic. We're not going to get bogged down in dense legalese, but look at this timeline. The Children Act of 1989 in England and Wales, along with the 1995 Children Order in Northern Ireland, fundamentally shifted our whole perspective. It made it clear that a child isn't property, their welfare is paramount. And then later acts, like the 2004 Children Act, built on this by actually creating the role of children's commissioners to make sure children's rights are always represented at the absolute highest levels.
Moving right along to part 2, who gets to decide?
See, when a patient can't legally agree to be treated, a doctor is left in a highly precarious spot. I love this quote from Lord Donaldson. He brilliantly described consent as a flak jacket. It's this legal armor that protects doctors from liability when they examine or treat a child. Without this flak jacket, examining a patient, even if you're just trying to help them, is technically considered battery, which is a physical violation under the law. Now, the only exception is a sudden life or death emergency, which the law calls the doctrine of necessity. But otherwise, a doctor absolutely must have that flak jacket of consent before proceeding. So the big question is, who hands it to them?
Well, the law hands this flak jacket primarily to those with parental responsibility. Historically, the law might have viewed kids almost as property, but modern parental responsibility, it is entirely about duty. It's a strict legal obligation to make choices that serve the paramount welfare of the child. Here's something that actually surprises a lot of people. You can never, ever just assume an accompanying adult automatically has legal responsibility. If a child's parents were married or in a civil partnership at birth, okay, they both have it. An unmarried mother automatically gets it. But an unmarried father, he only has it if he's actually on the birth certificate or has a specific court order. And step-parents don't get it automatically at all. Just picture this. You're a stepdad. You rush your stepdaughter to the ER, only to realize you legally cannot consent to her treatment. Wild, right? Now, as a kid grows up, that autonomy starts to shift. A Gillick-competent child, someone under 16, can actually give valid consent themselves, whereas a non-competent child relies entirely on a proxy acting in their best interests. This is named after a landmark 1980s legal case, and Gillick competence basically acknowledges that, hey, kids mature at completely different rates. If a young person has sufficient understanding and intelligence to fully grasp what a medical treatment involves, they can put on that flak jacket themselves. It totally bypasses the need for parental permission. It really proves that medical autonomy isn't just an on-off switch that flips at age 16. It's much more of a sliding scale based on maturity.
Which brings us to part 3, determining best interests. So, how on earth do doctors and courts actually figure out what a child's best interest really is? When a child isn't Gillick competent, those proxies step in, but they can't just choose whatever they feel like. The law provides a very specific checklist ensuring the child's welfare stays paramount. The Children Act of 1989 explicitly demands that we look at the child's physical and emotional needs, their cultural and religious background, and get this, even their own ascertainable wishes, no matter how young they are. We have to evaluate the whole child, not just treat them like a clinical puzzle to be solved.
All right, part 4, when people disagree. Okay, the theory of best interests is elegant, right? But the reality is often incredibly messy. Let's look at a scenario. Jade is 14 months old. Her mother completely refuses the MMR vaccine, but her father demands it. So who decides? Under the Children Act, since parental responsibility is shared, the father's consent is technically enough to legally proceed. But just imagine the real-world fallout. A doctor rushing forward with only one parent's blessing risks detonating the entire family dynamic. It just goes to show that what is strictly legal isn't always what is ultimately best in practice. But what happens if it's life-saving care, and doctors and parents completely disagree? In these tragic, highly complex situations where a doctor wants to treat but parents refuse, or even vice versa, the courts absolutely must step in to make an impartial decision. Doctors cannot be forced to provide treatment they believe is clinically inappropriate, and at the same time, parents can't be forced to accept treatments they believe will harm their child. When communication just completely breaks down, a judge has to use that welfare checklist we talked about to make the final, definitive call. Take the incredibly emotional case of baby Charlotte Wyatt. The courts had to weigh the reality of her severe pain and prognosis against her parents' very strong opposition to withholding ventilation. Charlotte was born extremely prematurely. Her doctors believed her cognitive function was minimal, but her capacity to feel pain was very high, giving her a really grim survival outlook. Her parents fiercely disagreed. The hospital did the right thing legally here. They went to the courts to ask for a declaration on her best interests, ensuring the law was their ultimate guide. On the flip side, look at the David Glass case. David was severely disabled, and doctors administered diamorphine and placed a do not resuscitate order on his file, directly opposing his mother's wishes. And here's the kicker. They never sought emergency court approval. The European court later ruled that this was a disproportionate interference with their right to family life. By skipping the court system entirely, the doctors operated without their legal flak jacket, and in doing so, violated fundamental human rights. And this right here is exactly why modern legal precedents heavily push for mediation first, recognizing that courts should be an absolute last resort. The Great Ormond Street Hospital versus Yates case explicitly pointed out that dragging a grieving family and an exhausted medical team into a courtroom should be avoided whenever possible. The best practice, always, is to communicate. Finally, let's look at Part 5, the rules of confidentiality. Just because a patient is young, it absolutely does not mean their medical records are an open book. The GMC makes it crystal clear that the exact same rigorous standards of confidentiality we apply to adults apply directly to children and young people too. If a child is GILET competent, meaning they actually have the maturity to consent to their own treatment, they also have the absolute right to have their medical information kept completely private, even from their own parents. But, there's always a but. There are strict exceptions where confidentiality can be legally breached. This is particularly true if a child's safety or the wider public interest is at immediate risk. If a child is not yet GILET competent, and sharing information with a parent or a legal authority is literally the only way to protect them from harm, a doctor is legally and ethically bound to speak up. So it is always a constant balancing act between privacy and protection. To wrap up this explainer, just remember that while a child's welfare is paramount, they're always part of a wider family unit. This leaves us constantly having to balance individual rights with highly complex family dynamics. The law, from the Foundational Children Act of 1989 right through to today's GMC guidelines, demands that doctors treat not just the ailment, but the whole child within their family context. So I'll leave you with this final thought to ponder. As medical science continues to advance and our understanding of childhood independence evolves, will our legal definitions of best interests be able to keep up? Or will the courtroom become an even more frequent battleground for family autonomy? Thanks so much for joining me, and keep asking the hard questions.